Good morning, everyone. I'm Dr. Charlotte Refsum. I'm a former GP and I'm the Director of Health Policy here at TBI. It feels like a really pivotal moment for prevention. Not only do we have exciting new drugs and treatments for preventable illnesses, but we now have the ability to target them more effectively at those that need them, based on each individual's risk of ill health. Underpinning our ability to do that is data. And countries that are investing in their data infrastructure are reaping the rewards for patients, for the health system, and for the wider economy. Denmark is a good example. Over the last 30 years, it has invested in its data infrastructure and seen its life science industry increase tenfold. Just one of those companies, Novo Nordic, has revenues eclipsing the national income of the entire country. The UK is well placed to follow in Denmark's footsteps, but it will require investment. Our health data infrastructure is fragmented, it is siloed, and it is difficult to access. The UK should make two big investments to make sure the NHS is ready for the AI era. The first is a digital health record for every citizen, and the second is a national data trust to support R&D in the UK. Macroeconomic analysis that we published today shows that if we invest in that way, it will be worth it. And here to discuss that in more detail is John-Arne Røttingen, CEO of the Wellcome Trust, Andrew Scott, Professor of Economics at LSE and author of that report, and our chairman, Tony Blair. As Chief Executive of the Wellcome Trust. Wellcome, obviously the biggest funder of R&D in the UK outside of the government. I wonder if you could give us a flavour here today of what some of those research and development projects are that you're investing in.
Well, thank you. And you mentioned Novo Nordisk, so they are starting to outcompete us, but we are still among the three biggest global health research funders, and which is the biggest foundations in the world, prioritizing, investing in research to improve health for everyone. We fund through two modes in a way. Discovery mode, really making sure that we can find the new insights, the new breakthroughs, and then the solution mode, where we have prioritized infectious diseases, in particular those affecting the most deprived context, low-income countries, climate and health, which is definitely impacting all of us already, and then mental health. That is an increasing problem across the world, and I think we saw from the pandemic is something we really need to handle together.
Perfect. And obviously the UK has a really huge advantage in this area and is already world leading, but there are still some barriers that exist towards progressing in R&D in this area, aren't there?
Yeah, and in a way I can use my own background as a history, because I came to the UK for the first time 25 years ago, and I went to the UK to come to the superpowers of life science. I really wanted to be among the best, be among global talents, international community, and that changed my career. I was shifting towards global health, and I was really inspired by working in an international community. Today, we are concerned at the Wellcome Trust that UK may start lagging behind. And it's because of, in particular, the barriers to getting global and international talent. And some numbers from Royal Society recently indicate that in Germany and France, the cost of actually visa and surcharges is 30 or 20 times less than in the UK. So it's a big cost barrier, and it's something needs to be corrected. And then it's about infrastructure, making sure that the UK still have the best labs, the best health data. Definitely, we heard already now in the introduction, I think health data and the opportunity to integrate health data across administrative data, population health data, cohorts, and also data from labs. I think it's fantastic. It's a comparative advantage the UK has, but it needs regulations that are in line with that, and it needs investments in technologies and the opportunities. And we are here to support and to be a part of this. Wellcome is investing 2/3 of our annual investments of 1.6 billion in grounds for research here in the UK. That's a historic legacy. We are driven more and more by making sure that we have impact from our funding. And in a way, UK needs to compete to actually demonstrate that the UK is among the best places to do life science and health research.
So you've talked about the importance of bringing talent over and the importance of data and the importance of infrastructure. What about the working relationship with the NHS, between life sciences and the NHS?
No, to me, as I already mentioned, I think health data is a comparative advantage of countries like UK and also the Nordic countries. As you hear from my accent, I'm from Norway. The other Scandinavian countries have the same benefits of actually linked data across the full population. You talked about individual population health management. How can we really integrate all the data that actually we routinely collect into a learning population health system, a learning health system? NHS is at the core of that. There's so many more opportunities. Now the data seem to be locked in different parts of the system. How can this become really a global resource, but really an opportunity for UK researchers to excel and to make public-private partnerships and really drive to new insights, very relevant insights that will make us actually have a more sustainable healthcare system.
Yeah, I mean, I mentioned Denmark. Are there any other countries that you think have particularly exemplar data health infrastructures?
As I mentioned, I think the Scandinavian countries are similar in that sense. We have in Scandinavia personal identifiers, so it means it's possible to link the administrative health data with health registries, national registries. I think in particular Sweden has had a long tradition on so-called quality registries, actually deep dives in different disease domains, being able to follow the quality of care, and increasingly using that to inform decision-making in the clinical setting. And then linking that to genomics, to proteomics, and large-scale cohort data. I really believe the Nordics with the UK have a big advantage, and very different from the US. And as you know, the most of life science and the big competitor is really in the US. They don't have that opportunity to really look at the population at scale and link and make sure that we have solid follow-up in clinical trials and actually can provide the new insights that really can drive population health, because that's why we're here. It's really to improve the health of the population. That's the ambition we need to have.
Clinical trials are a bit of a sore point for us in the UK because we had such a sharp drop-off in our clinical trials over the last sort of couple of years. Do you have any advice about how to pick that up in the UK?
Yeah, first of all, I think UK should still be proud of the trials the UK run during the COVID pandemic. I was leading the trial coordination board of Europe, and sorry, but UK is currently not in that Europe definition. It can improve, but actually just seeing how the UK managed to recruit quickly to the recovery trial, to the Reimagine trial, to the principal trial in primary care, it was fantastic and much more effective than the sum of European countries. So I think UK should be really proud of the ability to do large-scale pragmatic trials, integrating data, using the administrative data as outcome data in the trials. Then about recruitment and actually the number of trials, I think it's really about making sure that there is room and opportunity for clinicians to do research. The numbers are concerning in the UK. The proportion of consultants in the NHS that have a research background and also have the ability and opportunity to do research is going down. I think this is something that all funders, government funders and charities like Wellcome need to work together on, but with government, and making sure that there is space in the NHS to do proper research, because research is the cornerstone for the long-term improvement of healthcare. It's the cornerstone for a learning health system. NHS will be better driven by research, and it's not sort of outside and something additional or something we can only do when we can afford it. It's something really needs to be integrated, and that links back to the opportunities on health data and linking the research activities to the clinical work, to the improvement, and to the population health management.
And just finally, you mentioned COVID there, and I wondered if you had any insights into, what are some of the lessons we can learn from COVID and the way we use data during the pandemic?
So I was then not here, but I believe that all countries saw that if we really decide to do it together, we can have a much faster intelligence in a way. We just heard about the police intelligence. I think we can have much more of a intelligence with proper data protection and privacy, definitely, then making sure that we can follow the health of the population, that we can intervene at the population level. Of course, it needs to happen through primary care practice and so forth, but at least have that ambition level. The surveys the Office of National Statistics did here has, I think, a lot of good opportunities. And the question is, how can we take sort of the learning from the burning platform we really had during the epidemic? We talked about the barriers to clinical trials, just the speed of getting approval of clinical trials much faster during the pandemic. Why cannot that be the norm? Why cannot we use actually the fact that we managed to work collaboratively across regulators, academia, private sector during the pandemic, and actually take that with us into a normal period? So I would say that's a major learning. We can do better, so why don't we do better?
Agreed. I just wanted to turn to Andrew at this point, because we've heard a bit from John-Arne about the importance of R&D and how that can be a driver of economic development. But we've just published this paper together, which you authored, on prevention and the ways in which healthcare and population health can drive economic growth. So do you want to talk a little bit about that paper?
Yeah, so I'm a macroeconomist, and it's been interesting throughout my career talking to various governments how there's sort of a health system and an economic system, and the two are separate. But there was a really key statistic was put up on the video that in the UK, life expectancy since the formation of the NHS has gone up from 68 to 81. And in fact, if you look at the ONS data, 50% of children born today are expected to live into their 90s. And that requires a really big change in the health system, because we've got to make sure people aren't just living for longer, but they're healthier for longer and they're productive for longer. And if you look at the economy between 50 and 65, the number of people working falls from about 80% to about 0.25%. And a large reason why people drop out of the labour market is a poor health. So as we have more and more older people, keeping people healthy for longer is key, not just for their own health, but to keep them in work. Age 50 to 65, you've got a 5% chance of leaving the labour market. But that triples if you have a cardiovascular incident, it quadruples if you get a diagnosis of cancer, and it's 5 times higher if you have a stroke. So preventative health not just keeps you healthy for longer, keeps you working for longer. So you're getting this sort of health having first order macro effects. And it's kind of been the missing link, I think, in how we think about economic policy. And as growth slows down, putting pressure on health budgets, and health budgets get ever more absorbed dealing with the current disease burden, we're trapped in a vicious circle. So a focus on prevention, I think, can help us turn that vicious circle into a virtuous one.
So, I know from personal experience that clinicians have been talking about prevention for a long time and extolling its virtues, but policymakers are often a little more sceptical. And so I wonder, what came through in your paper, about, you have the thing in there about the national accounting mechanism. I wonder if you could talk a bit about that.
Yeah, so we're talking about innovation, and it's not just innovation in how we do delivery, but also how we evaluate things. And for me, every economist tell you health is incredibly important. During COVID, we took steps to shutter the economy to save lives. So we know that health is first and foremost really important. And to me, that's the main reason for doing prevention, because when you have more and more age-related diseases, prevention keeps you healthy, and that's valuable. But the second thing is, I think we've got to think about interventions not just in terms of how they impact health, but do they create additional resources that helps you fund this most important thing? And for me, that was sort of developing the tools and fitting them together, because there's 3 things that I think drive this increasing focus on prevention. There's always been talk about prevention. The first is the current system is unsustainable. If we keep treating current disease, we're going to spend ever more money achieving not improvements in health, but ever more cost. Secondly, we're seeing the economic impact of this. So if we can boost macroeconomic growth, where are the levers? And I kind of can't see a bigger macroeconomic free lunch right now than keeping people healthy so they can work up to the state pension age. We know it's good for all sorts of things, good for inequality, good for the economy, and good for health. It just seems utterly key. And of course, the other thing, and there's several people in this report, John Bell, John Deanfield, many others, we've got this innovation happening around prevention. We've got data, we've got AI, we've got a better understanding of diseases. We know that intervening in a few key risk factors affect multiple diseases downstream. So you've got an urgent need, you've got the ability to get the financing going through economic intervention, and you've got increasingly the medical capability to do it. So I think that's now why it's getting ever more important.
Yeah. One of the worries about prevention is sometimes that it'll take too long to realise benefits. How quickly do you think we could see benefits from reducing the incidence of cardiovascular disease?
Well, that was really interesting to me doing the work, because what we found was that if you could reduce 6 major diseases by around 20% in terms of their incidence, that's not curing people, that's just stopping 20% inflow into becoming ill. You get a sort of a 0.75% increase in GDP in 5 years. Now, I don't know if you get excited by 0.75 percentage point of GDP, but it's a big number. It's £20 billion, and there's £10 billion of fiscal savings that come from that. And that's quite quick. So actually, I did hear the story repeatedly that prevention takes too long, but actually you do get some pretty quick effects coming through. But it's true that the really big stuff happens later. This is an investment. Prevention is an investment in our future health. And I've focused on those 50 to 64-year-olds where if you intervene now, you increase their chances of staying in work in the next year or two. But of course, if you start with people in their 30s, you're going to make them much more likely to be in work when they get to 50s. So, this is how you really reap the benefits. And prevention's an investment. And I think you've got to have fiscal rules that give you scope to do that investment. I think there's also institutional issues that mean you want to keep prevention outside of the current intervention system. And then, although you can get these gains, we've got to find innovative ways of financing. The innovation and investment is the words we keep using today. AI, of course, gives us this ability to invest and innovate, but this adaptation to longer life and changing the health system also requires investment in innovation. And it's across the board, not just in delivery and evaluation, but also in financing. So how you ring-fence prevention to provide alternative finance instruments, I think is really important.
Thank you. Then, Tony, can I just ask, from a policy perspective and getting some of this done, it's clear what the need is, it's clear what some of the benefit is, but in terms of achieving this transformation in the data infrastructure, prioritising science, we've heard a lot of really promising things, even over the last 24 hours, about how DCIT is going to be considered a driver of economic growth and bringing in experts and ministers like Sir Patrick Vallance. But what sort of challenges do you think that department will face in terms of trying to turn this round and turn this into policy?
Well, fortunately, we're going to hear from Wes shortly, who's with us, and one of the, I think, most exciting things about the new government is that you've got people like him and others who are prepared to think in a new way. And the hardest thing about government is always, as you're trying to deal with all the immediate, sort of build in the long-term strategic thinking at the same time. And it really is the case, as you just heard from John-Arne and Andrew. I mean, there is a lot that's new. What is new is the capabilities we've got on research and the use of data. What's new are the treatments. There are extraordinary things happening in the world of diagnostics, in treatment, and you can see even for things like mental health, how you can have a massive difference made by the use of technology. And then, the work that Andrew and his team is doing, and just to say he's one of Britain's foremost economists, I think it's fair to say you had a certain amount of interaction with the Treasury and the work that you did, which is, by the way, very positive, the fact that the Treasury were prepared to engage in the work that he did. And this is the future, and that's why as I say to people, because it's possible to think of the present situation and think, it's great to be in government, but what a mountain to climb. But actually, it's great to be in government because there's a lot of potential solutions that are there to be taken up.
Yeah. And we've actually published a paper quite recently on some suggestions for how to transform the data infrastructure. We've talked about the need for a digital health record and the need for a national data trust. I don't know if you wanted to talk a little bit about either of those. And
Well, it's just, I think the thing that's hardest, and I can say this, talking about one of my children the other day, and I was saying, we can do this for old people and this for old people, and he said to me, "Dad, you are an old person." Sorry to have to tell you this, but I remember actually when I was in government, and Paddy Ashdown, may rest in peace, told me about email. I said to him, "Paddy, this is never going to catch on." I think sometimes it's hard for people just to get their heads around what it's going to take, but people do change. I mean, I can't remember who it was saying earlier, I think it was Rajiv talking about what they did in India. People do adapt to technology, but just think about adapting to technology in the sense that you're actually monitoring your own health, that you're understanding what you should do and shouldn't do, that you've got the ability through an AI digital assistant to get a much clearer understanding of the things that are good for you, the things that are not good for you, how you manage, for example, chronic conditions today can be completely transformed. So I think the most important thing, and this is one of the things you kind of learn in life, never mind politics, is just to have imagination.
Perfect. Well, we're at time, but thank you so much for this discussion. I'm really excited about the future of health data and prevention. Thank you.
Thank you very much. Thank you.